Yo, yo, yo. Hey guys, welcome back to another awesome edition of the Best Practices Show. I love this because I get to interview some of the greatest minds in all of dentistry. And we bring back a regular guest, Dr. Drew McDonald. This kid is awesome. He's an incredible teacher. And today we talk about how airway, jaw joints, and autonomic nervous system issues are creating today's orthodontic patients. You have to listen to this. It is awesome. So hope you guys enjoy it, and we'll see you soon. Hey guys, welcome back to the Best Practices Show podcast. Have you noticed this? Orthodontics is changing. It's changing a lot. And today I bring on one of the rock stars in all of orthodontics. He's an awesome human being. His name is Dr. Drew McDonald. And we're going to be talking about what lies beneath, how airway, jaw joints, and autonomic nervous system issues are creating today's orthodontic patients. Drew, thanks for being back, brother. I appreciate you.
Absolutely. Thanks for having me. I'm always loving hanging out with you. I know before the show we got to catch up, but this will be even more fun to go through all the new stuff that's happening here.
Yeah, and before we do, because I'm going to have you define what, I have a new set of words, autonomic nervous. I don't think I've ever said that in my life. So he's going to define what that means and how it fits. But I have to start here. You're in a new background. You got there's a new setting behind you. What's going on, brother?
Yeah, if you take a look, there's palm trees instead of the desert here. So I recently relocated. I sold my practice in Albuquerque, New Mexico, and relocated out to St. Petersburg, Florida. We're off and rolling. I'm seeing a lot of new patients. We're booked out already. I feel like I was meant to be here, quite honestly. So, but I'm right downtown St. Pete, where all the history of dentistry is, all the occlusion, all the people that I've learned from have had a lot of roots here. And honestly, I'm so excited to plug in and be part of this community and do what I do, and also do it with other people who I've really wanted to work with and who I've worked with a long time, like Dr. Brian Shaw, before him, Dr. Mark Piper, who was down here. And of course, we have so many Dawson Center graduates. We have so many people who really understand occlusion. And, I, as an orthodontist, get to plug into so many great treatment plans and with so many great people down here. It's an honor to be here, and I'm so excited to be off and rolling.
Yeah, I'm so happy for you, brother. I've got family in the area, so I'm going to be sending them your way. Hopefully you'll keep them on the nice list. So we'll see what happens. But yeah. We're so proud. If you guys haven't listened to anything Drew has done on the podcast, he's an amazing leader, great teacher. And he's even doing a pediatric TMJ study club that we'll talk a little bit about. This guy is just on the forefront of making us think differently, and it's powerful. And I'll say this about you because you won't brag, but we get a lot of requests for masterclass replays. Drew, I've had some of the best names in all of dentistry do masterclass. The number one request of all time is always one of two Drew's masterclasses. And you'll get a glimpse of this today on how this guy thinks. And we're just so proud of you. So take us through the whole why. Why is this topic so important that we're going to be talking about?
Yeah, as we were talking earlier, I wanted to illustrate, and I back to the two master classes I've done already, and what I speak and lecture about is that, orthodontics is so much more than straight teeth. People probably get sick of me saying that, but, the three big topics we're going to cover today are really at the heart of what drives bad jaw development, what drives bad, teeth positioning, how, even the function of our jaws are so related to things far, far away from teeth. And sadly in orthodontics forever, and I think that it's changing because we've got great people like Becca Baca, Mariana Evans, so many other friends and other non-orthodontists like Jim McKee, Brian Shaw, who's a surgeon, like I said, that I work with, who are really driving our understanding of how these foundational issues of the airway, the joints, of even things in our neck and our nervous system really do screw up growth. And, it's definitely the biggest forefront of orthodontics right now is our understanding of how can we intercept these things and how do we get to work collaboratively with other people, not just as orthodontists, but to actually get to the heart of the problem, help resolve it, and also really understand what is our piece in this, because we can't do it alone. And general dentists can't do it alone, neither can airway specialists. We have to have a team. And so as we talk today, I'm going to go through how each of these, especially the airway, the joints, nervous system issues can all contribute to the problem. And how do we solve this? How do we get our patients better, not just from a teeth standpoint, but from an overall health standpoint?
Right. I love it. I love it. And where do I even start? Take me through the basics of this.
Yeah, so I kind of want to start with I always start with controversy, I guess, but a very kind of recent phenomena in our orthodontic culture community has been to, embrace or shy away from CBCT imaging or advanced imaging of our patients. There was a very recent study that was taken two ways by orthodontists, and especially if you look at any Facebook group, any kind of thing like that, it's very polarizing. But basically, this article, amongst several others, talked about the high frequency of incidental findings whenever we take a full volume CBCT image. And so what some people took that as is, well, we don't need CBCT. We don't want to be responsible for more than just the part that we do, which is the teeth part, right? Or even just the jaws and the growth. So why don't we just stay with our two-dimensional x-rays, our lateral ceph, our pano, because that's home for us. And we know what to look at in those x-rays because it's what we were taught in school. We know if there's something weird in a certain area, then we send it to a radiologist. But ultimately, the other half of, and I would say sadly minority of what orthodontics took that study as there's a lot of things under the surface that come up over and over and over again in these pre-orthodontic patients that are way too common to just overlook. And so what the one study amongst others really did show us was that aside from teeth, kind of findings, the number one incidental finding on orthodontic patients were problems with noses and sinuses, meaning the airway. Why would that be? Well, if we know from lots of literature, the wave is here on literature, by the way, on all of these topics of airway, joints, neck, it's all here if you know where to look at it, and it's even in our orthodontic journals. But ultimately, how we breathe, especially breathing through your nose versus through your mouth, really does affect your facial growth when you're young and growing. Yeah. And if you have nasal issues or sinus issues or just in general problems with nasal breathing, we see maxillas don't grow properly. We see narrow maxillas. We see poor tongue posture, which can influence other growth, especially of the lower face. And so it's no coincidence that, of course, these orthodontic patients who have crowding of their teeth, narrow jaws, have nasal issues. And we're treating them as an incidental finding. That's not an incidental finding. That is a correlational finding. We 100% see these things, and they are certainly part of what's driving that patient to be in our orthodontic chair. So that's just the airway side. The next part is on that same study. And again, there's groups of studies at CBCTs that were taken on pre-orthodontic patients. The either third or fifth, depending on which article you look at, other incidental finding are issues with jaw joints. So again, us as orthodontists, if we take a CBCT thinking, a full volume and thinking, hey, we're going to correct that class 2 mandible or that retrognathic mandible, and all of a sudden we see, joints that are flattened or not growing well, that again is not just an incidental finding. That's part of what we have to treat in this patient. We cannot overlook the airway. We can't overlook the joints, because what we also know from literature is that whenever you have a jaw joint issue, specifically a disc displacement in a young growing child, the mandible does not grow on that side. And if it's a bilateral disc displacement, the mandible doesn't grow on both sides and we get a big class 2. Well, as orthodontists, what is our whole world? At my private practice, I'd say 70% of my patients are class 2 of some variety. They're either bilaterally, they're really deep overbite, overjet, or one side is asymmetric more than the other. And what I see over and over again on the MRIs that I take, not just CBCTs, but the MRIs that I take after I see a jaw joint issue on the CBCT, is that the discs are off and they're not protecting the growth center of the condyle. So again, is this an incidental finding? No, this is part of why this patient has this bite. Those jaw joint issues cannot just be chalked up to, oh, it's an incidental finding, we'll refer to somebody else. We as orthodontists have to understand what we just saw. And we also know how to take the next step, which is that, if we see it on a CBCT, then the next step is we need soft tissue imaging, which is the MRI of the joint. Dr. Mark Piper taught us so much about MRI imaging and the diagnostics that happen within the joint. Dr. Brian Shaw, who took over for Dr. Mark Piper, again, has continued and passed that baton. And then our good friend, Dr. Jim McKee, is just the man. He teaches the world at Spear and everything and all these other places. This is common. These jaw joint issues, this disc displacement, this lack of growth of the mandible is not something we can hide behind. And as orthodontists, again, if we encounter a disc that's displaced, and let's just say 2 scenarios play out, but one of which is that the disc does not get back over the top of the condyle, are we going to be able to help this patient grow? Absolutely not. There's studies, again, very good studies that are recent and old, that show that when the disc is off, and if you try and help that patient grow with a Herbst or a twin block or some functional appliance, they actually get worse. Mm-hmm. And there's a very great study that came out about a year ago. I'm blanking on the name, but basically this group of patients, they all had one disc that was confirmed to be off on the MRI. The other side of their same jaw, so same patient, had a disc that was on. And basically, these patients, there were multiple patients that had the same scenario. They were all put into functional appliances, things that bring the mandible forward in hopes that the mandible will grow. And what they saw is that the side that had the disc over the top of the condyle, they saw condylar growth on that side. But on the other side that did not have the disc over the top of the condyle, they saw either lack of growth or degeneration. That's not good. Right. So us as orthodontists, again, we cannot just go blindly into these orthodontic cases, especially when such a population of our everyday orthodontic patients are class 2. And so whenever you see a class 2, we have to know, is this a joint patient? And how much of a joint patient is it? And the answer, sadly, is often way too much. It's scary under there. There's jaw joint issues lurking in these class 2 patients. So we have to know what to do. And so I can't say this enough. That's not an incidental finding anymore. That is 100% part of this patient, and it needs to be 100% part of how do we treat the patient based off what we saw in the imaging. Yeah. So I get a little passionate talking about joints, as you can tell.
Well, let's just go there. You're one of the nicest human beings ever, and I know you don't like conflict, but where's the conflict coming from? When you said, let's start with controversy, take us into the eye of the hurricane. Where is that coming from?
A lot of it is just how we've always done it. And right. You and I have talked about this on past shows. That's kind of the stunting of our growth as a profession, is that, especially the loudest voices in orthodontic communities right now are very anti this, because it's just what they weren't taught this. Right. And I also believe, and this is just me personally, but I also believe it's a lot of, well, do we really want to be responsible for this if we learn about it? Because now our world just got way harder. If our whole world used to be just, hey, we can straighten those teeth, and that's easy, because, quite honestly, an algorithm on a computer can do that right now. I hate to say that because it dumbs down our orthodontic world, right. But aligners and a technician on the other side can really dial in nice straight teeth. Are they functional? Probably not. Are they in the right place with relation to the airway or the joints or some other stuff we'll talk about in a minute? Probably not, especially. And why is that? Because if you just look at the teeth at the surface, we're missing 90% of the iceberg here. And the iceberg, again, is all the stuff under the surface that's really going to screw up our day, screw up our results, screw up our patients potentially the rest of their life. Yeah. So we have to know where to look, and we have to evolve as a profession to get there. And again, I know that there are those of us who are pushing, and I think we're starting to win in terms of the wave coming with people looking at airway side and starting to look at joints more. But it's an uphill battle right now, just because the biggest, loudest voices, the people that talk at all the ortho conferences, really are kind of anti this. And again, I think we'll get there, but it's going to take a revolution, and I think we're underway here.
Yeah. So let me be one of the 32-year-old or 33-year-old dentists listening. I'm a GP. Drew, I'm on the other side of the country. I'm listening to this. I'm totally picking up what you're putting down. Nobody wants to do imaging. Like, come on, man. Like, what do I do? Like, give me a nugget. Where do I start?
Yeah. So the biggest thing I want to start with is really, as a GP, you are the front line and ultimately the quarterback, or should be, because, as an orthodontist, this is in the traditional model of orthodontics. A patient walks in, we assess their teeth, and they are basically expecting, hey, I'm here for the teeth show. And to have that nice shiny smile at the end of it. And so it kind of has lent itself traditionally in orthodontics to be a higher volume, type of practice where there's a lot more auxiliary patient, help in terms of our assistants that can do a lot of our adjustments and the tasks. And so, as an orthodontist, we kind of have to halt the wheels if we start to, look a little further underneath the surface in terms of at joints and airway and all of this. So as a GP, what would be very helpful is if you recognize the signs of an airway issue or a jaw joint issue in your patient at their hygiene check, and if you order the necessary imaging with CBCT and hopefully an MRI, that makes the communication with your orthodontist so much better. Because for one, it's not a barrier anymore, because the orthodontist, is not. Their office, most offices are not geared to do the CBCT and the MRI. But as a general practitioner, if you have that focus, that's even better, because now your referral comes to me as the orthodontist saying, the CBCT showed they have significant airway issues. It also showed they have jaw joint degeneration or a lack of growth here. And oh, by the way, their MRI shows that they have disc displacement, whether it's reducing or non-reducing. We need to land this plane with these things in mind. Right. Because, if all we're trying to do is straighten the teeth, but we didn't expand the maxilla to help with the nasal breathing, or if we didn't help the mandible grow forward to help with the pharyngeal airway, or if we land the bite in a spot that's off the disc where it could be under the disc, those are all very important things that an orthodontist want. As an orthodontist, I would love to know that and not have to do the imaging myself. But with the way I practiced, I didn't have that luxury whenever I was in Albuquerque, and now I have a lot more people imaging. But as an orthodontist, our world gets much easier if that work is done ahead of time. And then again, it becomes a collaborative approach to orthodontics in this patient occlusion, because you as the general practitioner, me as the orthodontist, probably some other people like myofunctional therapist or other people that are part of the team, we all know what we're treating now. And it's not just straighten the teeth. The goal is much bigger. Let's help this patient on a bigger level with, potentially airway joints, the whole system working where it should be. So, one of the biggest things that we teach, again, at Chicago Study Club, I'm not trying to put a plug in, but I guess I am right now, is, that is a general practitioner geared group where Dr. Jim McKee, Dr. Seth Atkins, Dr. Kurt Ringhofer, and myself are all talking about, how to order the imaging, how to establish the relationship with your imaging center. And then ultimately, what does it mean towards treatment? And then what do you tell your orthodontist? What do you tell your jaw surgeon that needs to happen given what we just saw in this imaging? Yeah. So I'll kind of end plug there, because I know that's not what today's about, but it was a little bit. But ultimately, that is something that if you listening don't, if you have the capability in your community to do this before you send the case to the orthodontist, your orthodontist will love you, because now they're not having to carry the bag for all of that, because now it's a shared shared interest, shared approach, and the orthodontist has a piece of it, not just all of it. So that's, 100%. If you can do that ahead, you are helping everybody.
Yeah. And I know you might be afraid to plug the Chicago Study Club, but I'll forever plug it. I mean, there's some powerful minds in there, and transformational learning that you guys are committed to, which we'll circle back. But you have to define autonomic nervous system issues. So take us through that.
I gave you the tongue twister for the other half of this. So I'm gonna kind of bring. It's gonna sound like I'm going to crazy town first, and then I'm gonna bring it home.
Okay.
But we all learn in dental school that your body works in either fight or flight or rest and digest mode, right? That's your autonomic nervous system. That's your sympathetics and your parasympathetics. Well, what we have sadly on our hands right now, in this, in our kids, in our adults, quite honestly, is just a big storm of sympathetic nervous system activity that is lying underneath the surface. So what do I mean by that? When your sympathetics are firing away, your body is in fight or flight constantly. And one of the big sources of our sympathetic nervous system to our head, our neck, and our shoulder actually is our ansa cervicalis. For any dentist, dental school or afterwards, you remember that little loop that they draw right there by your chin? That is part of your sympathetic nervous system. And one of the biggest influences of your sympathetics in your head, neck, and shoulder area is if you have cervical spine issues. And I cannot tell you how many little kids, how many adults, whenever I look at their CBCT x-ray and also in studies that they show, there are upper cervical issues everywhere. There are torsions, there are twists. I actually just before this met with a chiropractor who is here locally, who's an Atlas orthogonal chiropractor. Our world is the same. And essentially where I'm going with this is that when we have upper cervical misalignment, we start to compress those nerves that ultimately start firing and firing and firing our sympathetic nervous system. What does that look like as a patient? Now, if on one side of your head and neck you have a higher sympathetic tone, it constricts your blood vessels. Remember back to anatomy and physiology. If your sympathetics fight or flight are flying, your blood vessels constrict. And when that happens, we get less nutrients in our blood to our muscles, to our, just the whole side of our head, neck, and shoulders on that side. We get tighter muscles. We get dystonia. Dr. Mark Piper is the first person I ever heard say this. And ever since I heard him and saw what he was talking about, it changed my look on so many things with growth of kids and also with pain. Sadly, the pain part is the end stage, and I want to get them when it's just a growth issue as an orthodontist. But essentially what I see over and over and over again is that when we have upper cervicals off, and basically especially C1 does not move freely back into place. And if C1 is out and continues to put pressure on that nervous system on one side over and over and over again, what I see again is we get bad facial development on that side. We have tighter muscles, we have tighter muscle pull, we have less nutrients going to one side of our skeleton and our muscles. And I see asymmetric faces, especially the mid face, not just the mandible, but the mid face gets very, very asymmetric in this type of situation. I just had a patient last week that was 3.5 years old, referred for an airway issue, and his neck was terrible. And he's another kid that's just, again, if we don't get to the heart of his issues at 3.5, he had big tonsils, adenoids. Of course, we're going to work on that. The other things are, structurally expanding. But if his nervous system doesn't get corrected, this kid's not going to sleep well. He's not going to grow well. And it's just going to be more and more trouble. So that's the neck part of the nervous system. The other part, and I didn't mean to skip over this because it's probably the biggest, is how does our airway drive our sympathetic nervous system? Dr. Jeff Rouse talks about this all the time, that if we're not breathing well, our body is starting for oxygen, we flip into stress mode, right? So, classically, whenever we have mouth breathing kids or adults or patients with very small pharyngeal airways, they're not getting oxygen. And those patients, again, don't sleep well, right? Because our body it's in fight or flight. We need oxygen. We're gonna fire away our sympathetic so that our heart rate picks up and we pump more blood with more oxygen to our body to make up for this. And also we're going to, essentially kind of, come out of normal rest, because we're thinking, as humans, and, just our natural drive is to get oxygen, and we have to kind of wake ourselves up sometimes to do that. And so if your sympathetics are firing because of an airway issue, especially at nighttime when you should be sleeping, there's no way you're getting good sleep. It's like drinking 10 cups of coffee and trying to fall asleep and stay asleep. It just doesn't work. Yeah. And so from an autonomic standpoint, things that can drive up our autonomics are our airway, injuries to our upper cervicals, and even the newest foray is our diet. And not newest, that's been understood for a long time, but if we have issues with foods, if we have sensitivities to foods, if we have gut microbiome imbalances, our body flips into that gut brain situation, fires away too. So we have multiple sources of gasoline on this fire in terms of the sympathetics. What picks it up is a lot of things, and if that's firing away in ways it shouldn't be, especially in the head neck area, we're going to see growth issues, we're going to see muscle tightness, we're going to see sleep issues, all of it. Yeah. So 100% we have to know what we're looking at. And a lot of times the CBCT shows us those things too.
Yeah. And you and I have never talked about this, but do you know what the Aura ring is? Do you know what that is? Like, have you?
Yeah, I do.
Yeah. Okay. Yes. So I have one, and it's life-changing. Number one, Mike Buckner. Thank you so much. So I don't wear it during the day because everybody always asks me, what is that? What is that? So I wear it at night now. But what you're saying is absolutely true. When I don't tape my mouth, it's all over the map. When I have a couple glasses of wine and a cheeseburger too late, it knows it. It says, you slept terrible last night. Did you eat and have a little bit of alcohol? I'm like, be quiet. You can see your heart rate never got down below. And it was like a dumpster fire of sleep. So it's crazy what the data will show you, It's amazing.
Yeah, no, absolutely. Well, and on that note, I see it, like I said, from 3-year-olds to 73-year-olds essentially. But, at every patient that comes into my office, we have done for a while, and especially at the new office, sleep screenings. We do basically not the Aura ring, but I was doing a different device there for a while that I would have kids wear for at least 2 nights, if not 3. And good Lord, you've never seen worse sleep on the youngest of kids who need the most sleep. Their brain development, their overall growth. If they're not sleeping well, they're not growing. And you see it. Yeah, it's so sad because you see it present in 2 different ways often. One is the kid that's tiny for their age, or is very, very skinny, kind of looks like they can't put on weight. And sadly, the other side is the kids, and there's lots and lots of research that correlates pediatric sleep apnea to obesity. Yeah. And so sadly, the 2 situations come up very often in today's orthodontic patients, especially the young kids. And if we can be part of helping recognize more than just a teeth problem for our patients and steering them and referring or working collaboratively with other practitioners to help this all get better, we've done a much bigger job than what we thought we just should have done. So
yeah. And another thing, I think it's safe to say this is not going away. Would you agree?
No, not at all. I think
it's only getting bigger. Yeah. And number one, obviously you do a lot of education, and this fuels your passion. This is like a calling for you. It's not just a job. And I think when anybody finds that part of a job, quote unquote job, or a role, but that it also presents an incredible opportunity in orthodontics, don't you think? So if I'm an orthodontist listening, and I'm thinking like, Drew, you don't understand my practice. I got a lot of insurance. I don't know how. One of the things, in order to be successful, wildly successful in dentistry, you have to be different. And you can't be different just because. You're different because of a passion. Can you speak to that?
Yeah, I'll kind of dive back to the controversy side here, which is that I really sadly believe that a lot of the pushback from the orthodontic community on people who have stuck their neck up for the airway side, especially jaw joints over the years, has really kind of been because, it's just a gimmick to get someone in the door. They're saying they're doing these things, but is it just the same as what I do, and are they just my competitor? That's their way of differentiating. Well, like I said, is a sad way to think about it, because what I see overwhelmingly, what research supports over and over, and if you do take imaging and look, is that all of these things are present, most of them in every patient we've got to some level. And we have to know how to look at this and do better. And so for me, back to kind of my road to this was that I was getting frustrated with my only answer, especially with jaw joint patients. If they had a joint issue that was changing their bite after they had orthodontics, my only answer traditionally was that it was an idiopathic condylar resorption, and that's it. And I hate that word idiopathic because it means we don't know. And so ultimately, that's what led me to go see Dr. Mark Piper and meet Jim McKee. My good friend David Manzanares, who's a dentist in Albuquerque. He took me to this study club, and that weekend changed my life. It changed how I practice. It changed everything, because I could not stop seeing joint issues at the end of the day on all of the scans. And I was somebody who had a 3D X-ray in my office, but I would take it very limited. I would take it only to, oh yeah, we've got an impacted cuspid. I should probably see where that is in 3D. But, are you okay with me taking a 3D X-ray was kind of my conversation. I wasn't confident with it because I wasn't taught it. And then as soon as I saw that, I was like, why am I not taking full volume on every patient? Because all of these issues need to be assessed. On that note, we have responsibility as dentists and practitioners for, limiting radiation. But with today's technologies, good Lord, I mean, if you take a pano and a lateral ceph, and if you took any other, even a frontal ceph, you've got more radiation in those 3 two-dimensional images than you do in just one spin at the light mode of a 3D X-ray.
Right. And
so I feel like we can kind of stop with that argument that we're being irresponsible by taking 3D X-rays, because the newest the technologies we have now available are less than most 2D imaging systems that are still around. Yeah. At least the convergence of how many images we had to take to look at certain things. And so, I know I'm kind of getting off topic, but I needed to address that, because then everyone will say, oh, Drew just zaps everybody just for fun with the X-ray. So anyway, back to after I met Jim and Mark, that's where I was like, I need to have a 3D X-ray that's going to show this on. And oh, by the way, I treat kids, and some of them are wiggly kids. I need to be able to have a machine that allows me to do that. And I'm not going to comment on anything that I have, but ultimately I could not unsee the joint issues. Before I even became a joint guy, and this is what I think is kind of funny, is that, I've been painted as, I'm just the TMJ guy, yeah. I was in the Airway stuff way before, and I actually had some really great mentors in orthodontic residency who were very Airway forward. Dr. Hamilton, who was one of my mentors out there, Scott Hamilton, I should say. I also, my program directors, Laura Iwasaki, Jeff Nickel, oh my gosh, they were so forward thinking. I think I still think they're 30 years ahead of all of us. And so I love them. I thank them all just because they gave me the opportunity. But back to where I'm going with this is that, the Airway stuff, I was seeing that already on 2-dimensional images. You can see even on a pano if a nose is blocked. But ultimately, the 3D X-rays just shows us how much. And right. Does this patient need ENT involved in their life? Do they need other supportive therapies? I haven't even talked about tongue ties yet. Good Lord, that's a huge part of our life at this point. But ultimately, the imaging drives the treatment, and ultimately, we have to have a good sound diagnosis to make good decisions. Yeah. The other thing is we all speak imaging. I know that sounds funny, but the common denominator of everybody who's treating these patients is when you see something on an image, that's a black and white truth right in front of you. And as soon as everyone sees those and kind of shares those together, we know what we're dealing with. We're not just kind of guessing and saying and going off symptoms. We're going off, hard pictures in front of us. And so for me, back to communication, every time I take a 3D X-ray and I put it into my presentation that I show the patients, they see it, their dentist sees it, anybody else I'm referring that patient to, whether it's a surgeon, myofunctional therapist, whoever, we all need to see these images for our patients to understand what are we really treating.
Right.
And so often, again, it's an airway issue. It's a TMJ issue. It's upper cervicals, or it's tongue restrictions, fascial restrictions that we can see clinically. But we all need to speak the same language, and imaging is the way that we do that.
Yeah.
It really does marry all the worlds.
Yeah. And I know we're just opening the box right now. There's a lot to talk about and a lot to unpackage. You're going to be doing a master class on this and we'll share we haven't actually scheduled it yet, but you guys will see. If you're listening to the podcast, you want to listen to the 2 previous ones, just send me an email at Kirk@ActDental. I actually had to create an email template so I could just email it automatically. That's how much you'll love it. And I've even had some GPs say, can you send that to me? I'm going to send it to my orthodontist, and vice versa, so that they can at least start the conversation. And Drew is just a great teacher. So I want to do a couple of things, Drew. Like, I want to put some final thoughts to this. Then I want you to talk about what you're up to next. And then if somebody's listening to this and they just want to find out more about you, like, how do I start that process, or where do I go?
Yeah. So, kind of final thoughts. I'm not trying to repeat myself too much, but our world as orthodontists is so much bigger than teeth. And we also need to understand what piece we play, and also what responsibility other people as part of the team have too. Because again, we can't do this alone. The people we work with can't do it alone too. I'm very fortunate, again, whenever I was in Albuquerque, to have a great myofunctional therapist, Sandra Luz Gonzalez. One of the saddest pieces of me relocating from Albuquerque is that I won't see her as much as I did. We had a great relationship, treated so many patients together. What I've been very fortunate to have out here in St. Petersburg is a whole network of people in the Bay Area. Dr. Elizabeth D. There's so many myofunctional therapists I'm working with, and myofascial release therapists, and all of these people that really do complete the picture. But ultimately, again, when we see as an orthodontist a malocclusion, we need to start looking at how deep does this rabbit hole go, and who else needs to be involved. And one of the easiest ways that we can start that conversation with our team and also with the patient is with the imaging. Because again, if the imaging is showing that there's an airway issue, a joint issue, all of what we talked about here, then we need to start opening up our playbook and say, hey, this is who I would refer, or I want you to see to address this piece. And this is really my piece as the orthodontist. I can change structure, I can change the function, I can do a lot to support your joints and help your airway, but I can't remove your turbinates or your tonsils or adenoids. That's where you need to see the ENT. Or, you need to see this, tongue release specialist, or the upper cervical specialist to take care of these other issues. And so you become quarterback when you take the imaging, whether you're an orthodontist or a GP. But really the bottom line from today is that our world is way deeper than the surface. And we have to feel comfortable living under the surface here, because it's a little rough down there, but if you know how to navigate it, we're going to be safe. We're going to do good treatment. We're going to help people.
Yeah. Drew, you're just an amazing voice, amazing leader in the world of dentistry. I'm so freaking proud of you. I can't even stand it. So, but I want people, where do I go find out more about what you do? Now, I'll just say this. If you're a study club director and you haven't had Drew, what are you thinking? Like, bring Drew to your study club. It'll blow your mind. And I don't even know if he's doing that very much anymore. But if I want to follow what you're doing, where do I go? And then I'll put a link to the Chicago Study Club. I'm going to encourage you to check it out. It is invite only. And so not everybody gets in, because you guys want to create a group of learners. And then you got to give us a little insight. When's the Pediatric TMJ Study Club going to be done? So those are 3 asks, so.
No,
how do I find out more about you?
The Chicago Study Club I talked about throughout already, but and just follow the link there. It's a great group. Like I said, we try and keep it a smaller group so it doesn't get too crazy. And that's not to do anything, but we're potentially talking about having 2 groups, but keeping them smaller each, so that it's not, we don't want a huge, just 100 people and no one learns anything and you just, don't interact. We want it to be more intimate than that. So, but I would certainly follow the show notes, because we're pushing the envelope with our understanding. And again, it's not an orthodontically driven group. It is a GP, restorative dentists, people who care about occlusion and high level cases. And we go through case after case after case together, and it's from all aspects, but we're all, again, married by the imaging that really tells us whose piece is what for these patients. So anyone interested, I know that, definitely kind of check out the link that Kirk has here. On the note of study clubs and individual presentations, I do a full day presentation. It's 7 hours of everything you just heard here, plus perio. I didn't even talk about perio today. Holy cow. Anyway, so the biggest thing is, I do those type of things. The place to contact me from on that is my website, which is a new website. It's orthobymcdonald.com. Not to be confused with my old one, which I won't mention because it'll confuse everyone. So anyway, the last thing is, as you were asking, pretty much after every time that I do like a talk or, a program for study clubs, or even after Chicago Study Club, I get several emails about, if it's a general practitioner, it's like, I'm seeing this, how do I get my orthodontist on board? Or very often I get orthodontists afterwards who say, those patients you just showed, those are my patients I just had last week. Like, where do I go? How do I learn more? How do I learn to do the imaging, specifically the MRI imaging, because that's such a new thing. And so what's really spurred me over the last 4 years or so now has been, I had nowhere really to tell people to go as an orthodontist to learn more specifics of our orthodontic mechanics and stuff that really pertains very, very specifically to orthodontists, of how the imaging and the orthodontic treatment should go when we encounter these things. And so what I've put together and we're releasing later on this year is what I call a pediatric TMJ kind of continuum study club. That at first it's going to be lectures or there's recorded lectures. It'll all live online, basically on my website, which is the Ortho by McDonald website. But essentially it is a place to go to learn all of this, whether you're an orthodontist or GP. But essentially it's much more targeted towards our orthodontists and how do we execute when we see these things. So it's going to become a study club format after the first modules are there, because I want people to watch them, have base understanding, and then we can start really going to town together as orthodontists and really knowing and pushing the envelope when we have that base knowledge together. So I'm really excited for it. It was a lot of shooting and a lot of retakes and a lot of other stuff to make it happen, but I'm pumped for when it all comes out, and I hope other people like it. So
yeah. And when you look at this, I'm going to voluntold you. And when it's first released, you'll hear about it here first. Look at that. Do you like that?
Now I got to deliver on it. We'll get on.
There you go.
Yeah, for sure. It's coming.
Yeah. In any event, if you're not taking notes, this is how it works here. We're taking notes for you. So all the notes, everything that Drew has mentioned will be in the show notes. You can flip right up to the show notes, Stitcher, iTunes, Spotify, whatever you're listening to. Just go right down there. You're going to see links to everything that Drew's mentioned. Drew, thank you so much for being on, brother. Really appreciate you.
Yeah, absolutely. Thanks for having me, and I look forward to the next time.
Oh, it's going to be awesome. I might even just show up in your office and we'll do a show right there. It's a great place to go. So how far are you from the baseball stadium? How far are you from the baseball stadium?
Less than a mile from the baseball stadium, and they're actually rebuilding. They're building a brand new one. Should be done by 2029, I believe. So that's coming, and it's right downtown St. Pete. And then everything down here is hopping. It's a fun place to come visit. I hope that Dr. Brian Shaw and I didn't say this, but we're putting on some stuff later on this year down here in St. Petersburg for people who are interested. So it's a great place to come, learn, hang out, and good food and good times. So come on down and hang out, or just contact me if you want to come shadow or anything like that too. Not you, Kurt, but you can just hang out.
I'm just going to show up. I'm not even waiting for an invite. So, it is.
I'll find you outside the door one day. Yeah.
I'll be knocking on that window right behind you. Hey, buddy, what's going on?
Me.
It's just me. Oh gosh, he's back. Yeah. So awesome.
It's like Kirk Behrendt.
Yeah. Well, stick around while we say goodbye to everybody else. But thank you guys for listening to the Best Practices Show. I hope you enjoyed that as much as I did. And like I shared with you, he is an absolute rock star. So if you enjoyed today, do us a favor, hit the share button, share this with your friends. Keep sending us suggestions for things you guys want to see. I'll keep lining them up. and lots of good stuff on the way. So until we hear from you next time, or you hear from us next time, keep watching or keep listening to the Best Practices Show. You guys enjoy your day.